Lecture. Our first speaker comes from Austria, Dr. Troedhan. The topic is transcrestal hydrodynamic ultrasonic cavitational sinus lift, result of randomized clinical study. Please, the stage is yours.
Respected chair, respected colleagues, I'm proud to present to you today the results of our randomized controlled clinical trial regarding the development of our transcrestal hydrodynamic ultrasonic cavitational sinus lift. Since this is a very long word, I will just call it INTRALIFT. Now, we all know that the basic biological tissue necessary for bone regeneration in the subantral scaffold is the periosteum, because only this is the biological entity that is able to regrow the bone in the subantral scaffold. But, and this is our biggest problem, the Schneiderian membrane is very, very susceptible to shearing forces, which of course might lead to perforations or ruptures of the membranes, which then turns out that we have to finish the surgery without achieving the subantral augmentation. Contrary, when we apply hydraulic pressure to the sinus membrane, we are able to detach the sinus membrane, added with the piezotome-cavitational effect. What you can see here in this small video is that one of the first trials of our method to detach the sinus membrane with hydrodynamic pressure plus the cavitation effect on a sheet pad. And this then is the final result. As you can see here, a full detachment of the sinus membrane only by hydrodynamic forces plus the cavitation effect. So, after the proof of concept, we developed diamond-coated tips to carefully and transcrestally open the sinus floor, then to prepare a receptacle for a ventral mechanism to be applied to the transcrestal approach. Here you can see the TKW-4 tip, preparing the receptacle for the final TKW-5 tip. And with this tip, it's possible to detach the entire sinus membrane from the entire sinus floor within 5 seconds, only with hydraulic pressure, plus added the cavitation effect, which enhances the detachment process and gives a much higher safety regarding the detachment from the antrum. Now, our hypothesis after the first clinical applications was that the INTRALIFT might allow scalable sinus floor augmentations of any size and mesodistal extension similar to lateral approach sinus lifting with comparable or better clinical outcome regarding overall surgical success rate and post-surgical patient morbidity. So what did we do? We compared 1,063 INTRALIFT procedures with 1,009 lateral approach sinus lift procedures in between the year 2008 to 2015. Here you can see a typical case of an INTRALIFT procedure before and after. And this is what you have to face when you do a transcrestal approach with the INTRALIFT method. Once you detach the sinus membrane with the TKW-5 tip and you remove the tip, what you will see is the backflow of the 2.5 cubic milliliters of saline solution pumped between the sinus membrane and the antral floor. And this gives you the first proof that there was no perforation or no rupture of the sinus membrane subantrally. And since the approach has a diameter of approximately 2.8 millimeters, you will be in most cases also able to visually control if there was a perforation of the sinus membrane with the INTRALIFT method. What you will see here is a Valsalva test, and once the patient inhales, you will always see the membrane floating back substantially into the sinus cavity. And once the patient exhales, the membrane is floating back, of course expressing some of the blood that was acquired during the separation process. So this is very important. You have full visual control over this procedure like you have with the lateral approach sinus lift. And if your implant system allows, of course, you can apply the implants simultaneously. But this is not a feature of the INTRALIFT, but it's a feature of the different implant systems you might use. So for this you have to refer to your implant system and not to the INTRALIFT procedure. This is then the final result. And what is very important to mention is that, of course, according to the simple physics of the procedure, the implants will always be exactly in the center of the augmentation site. But this is simple physics, and it's not related specifically to this method. Now, when we start to speak about the results, we evaluated a lot of parameters, but the most important parameters for the clinician might be that the number of membrane perforations that occur with traditional lateral approach sinus lifting. And once you know the literature, you know that there are a lot of reports and clinical studies reporting sometimes 40–45% of ruptures during the sinus lift procedures. In our study, we had approximately 14.2% of perforation or ruptures, but with the INTRALIFT procedure, we were able to reduce the risk of perforations by 2/3. And of course, also the abortion of the procedures when a real vast rupture of the sinus membrane occurs was reduced by more than 50%. And of course, since it is a transcrestal approach, the overall osteotomy time was significantly shorter than with lateral approach sinus lifting. On the other hand, we were able to achieve exactly the same, or let's say without significant difference, the same augmentation height and augmentation volume in the sinus lift procedure, because in a lot of cases you will need large augmentations to insert 2 or 3 implants. So there is no difference between lateral approach sinus lifting and the INTRALIFT procedures. On the other hand, when we speak about post-surgical morbidity of the patient, like edema, bleeding, pain, or ecchymosis, we saw a reduction by more than 50% when we compared the classical traditional lateral approach sinus lift with the INTRALIFT procedure, which of course is in accordance to the situation that once you apply ultrasonic surgery to any kind of surgical procedure in oral surgery, you will always see a substantial reduction of post-surgical pain and swelling in the clinical routine. Now, what are the conclusions and clinical implications of this developed INTRALIFT method? Here you can see one of the cases where we did a bilateral INTRALIFT simultaneously in a very old patient, and you will always be able to see this typical pleasure dome, we call it the pleasure dome shape of the augmentation site, which really fills the entire subantral scaffold and gives a half dome shape like this. This is the right side, this is the left side. So, according to the results of our study, the INTRALIFT procedure suggests to be a superior alternative to lateral approach sinus lifting because it provides comparable augmentation volumes as lateral approach sinus lift with comparable surgery duration, but with significant less risk of intrasurgical complications and significant less post-surgical patient morbidity. And since the need for sinus lifting is always increasing, it's another discussion when we speak about short implants. We will hear a lecture then shortly afterwards. In a lot of cases, we absolutely need to do sinus lifting. And in this case, maybe the INTRALIFT would be the better alternative, especially for the ever-aging patients we have to treat. So, this is just a short outline of the bibliography. Of course, all our experimental setups and our multi-center studies were published, so if you're interested in, you're welcome to read them. And if you just want to get the essence of this lecture, you're free to download this lecture at our Academy's educational channel, and of course all the live surgery videos are also available with free access on our Academy's channel. I thank you very much for your attention, and if you have any questions, I will answer them.